pleasure to be back here. Again, I thank you all for inviting me. It's actually a great treat to see so many friends from Turkey and to hear their success stories in your country. Lymph node metastases in thyroid cancer, one might think is kind of a silly subject that we know all the answers, but I would say we don't even know where to begin. And now I'm going to specifically relate this to thyroid cancers of follicular cell origin, not parafollicular cell origin. And basically what I think made a lot of probably endocrinologists and endocrine surgeons interested in the lymph node story was that the American Thyroid Association said consider central neck dissection, prophylactic central neck dissection in all patients with papillary thyroid cancer. Now I'd have a big consider means think about it. Whether you do it or not is another question. So the question is, should the patients have selective central neck dissections? That is, you see nodes, you take them out. Or should they have a prophylactic? You don't see any nodes, but you still remove all the fibrofatty tissue in the central neck. Now I'm old enough that when I was a surgical resident, one of the most common options back in the 70s, one of the most common operations was actually neck dissections, because all the patients who had papillary thyroid cancers had prophylactic lateral neck dissections, not just central but lateral. And if it was positive on one side, we'd do the other side. And as I'll show you in some of my subsequent slides by Noguchi and the late Joe Addy, 80% of those patients had microscopic nodes in their thyroid glands. Excuse me, in their lymph nodes in their neck, in those who had papillary thyroid cancer. So we thought we were doing wonderful things, curing disease. But then there was a study by Hutter and Foote from Memorial Sloan Kettering, combination Memorial Sloan Kettering and Yale in 1970. And they looked at patients, about 80 patients who had prophylactic lateral neck dissections, not central but lateral, versus those who had therapeutic when they had developed nodes. And basically there was no statistical difference on whether they were treated when they had identifiable disease or microscopic disease. But no matter how good we are at something, as you know, it's not necessarily making something that's bad good, it's making something that's really good even better. So what would you want if you or your family member had papillary thyroid cancer? What is the appropriate operation? So briefly, I'll give you a little information on papillary thyroid cancer in general. Then I'll talk about lymph nodes and some of the information. And there's a fair consistency with the information. So this is the do buffet. I use it a lot. I like the sort of a happy face coming back. First of all, being invited to a conference and also to be re-invited is even more exciting because it means your first lecture wasn't terrible. So what do we know? This is an illustration from Freiburg, one of the first patients apparently depicted with thyroid cancer. So this would be a challenge to most of us today. I've certainly seen probably 10 patients like this in my career, and they can take much of the day to try to get a safe operation in all tumor disease. But we know that thyroid cancer is the most rapidly increasing cancer in women, and is now the seventh. It says here the seventh is now the sixth most common. You'll see on the next slide. And Scott Mundell, using the SEER database, showed cause-specific death from thyroid cancer, papillary thyroid cancer, is 93%. We know that papillary cancer accounts for about 85% of all, at least in the United States and iodine-rich countries, about all of thyroid cancers. Papillary thyroid cancer is the least aggressive. And I like to call it the rule of sevens. 7% of patients with papillary thyroid cancer, 14% of patients with follicular thyroid cancer, 21% of patients with Hürthle cell cancer, and 28% of patients with medullary cancer will be dead from their disease in 10 years. So it's a good way. When I do it with patients, I make it a 5 rather than 7. They both numbers work pretty well if you look at the prognostic. So even more updated, newer data shows that about 350,000 patients in the United States currently have thyroid cancer. So if you are looking for more patients to treat with thyroid cancer, first of all, just bring back all your patients who have been operated on for thyroid cancer in the past, and you'll find many are thyroid globulin positive, and they will do ultrasound, and you'll find they have lymph nodes on ultrasound examination. We know it's now the sixth most common cancer in women, and actually the second most common after breast cancer in women under 40. So it's a pretty common disease. And the incidence has increased almost 250% in the last 25 years. And it's very interesting that most of the studies suggested, well, sure, it's increasing, but these cancers are incidental cancers that are of no clinical consequence. Sam Wells, who I mentioned earlier in the lecture, said last year in a meeting we were both at, that looking at the NCI database, it appeared that there was actually more deaths from thyroid cancer and actually more large thyroid cancers using the NCI database. Stephanie Lee from using the Massachusetts database found the same thing in this study from Elaine Moran at the NCI, who's done a lot of great epidemiology work, showed that the tumors greater than 5 centimeters also increased during this period, and the tumor size and stage increased from 1988 to 2005, and the largest tumors increased by 5.7% in women and in men by Shannon studies. So it appears that although most of the tumors that we're seeing, the vast majority of why thyroid cancer is increasing so dramatically is because of detection. They're having ultrasounds for carotid disease, they're having MRIs for other things, and they see a so-called incidentaloma within the thyroid gland. What do we know? We know that thyroid cancer patients are at more risk if they have a history of radiation exposure to the neck. And the next slide you'll see some molecular biology, but you know that's usually associated with what? A RET PTC mutation, as from the studies from Chernobyl. We know that there's a family history of thyroid cancer. Our group is very interested. We're trying to find the genes predisposing to familial isolated thyroid cancer without associated conditions such as Cowden syndrome, Gardner syndrome, Carney syndrome, Werner syndrome in Japanese. Thyroid cancer accounts for 17% of the patients have thyroid cancer and Werner syndrome, which is a form of progeria, premature aging, in at least in Japanese citizens, but apparently not in Caucasians, as far as I can find. And there may be a higher frequency in patients with multiple MEN2A and 2B and familial hyper. Okay. Multinodular goiter, finding now with ultrasound, the ultrasonographers, they may have a patient you send or you do it yourself with ultrasonography. I encourage endocrinologists and surgeons to get proficient and very good at it, although we still send most of our patients to the radiologists to confirm it because they're better than we are at doing it, but I think everybody's getting better. But you'll see when they biopsy now, they may not even biopsy the biggest lesion in a multinodular goiter, which has classic typical lesions of looking like a colloid nodule, but they'll biopsy the 1.5 centimeter lesion, which has microcalcification or microcystination. And we also know in the familial, my fingers are too wide, I keep it. In the familial patients with thyroid cancer, they have many more multinodular goiters as well in other thyroid pathology. And goitrogens, iodine deficiency increases the risk of follicular thyroid cancer and carcinogens. In animals, you can give an animal a carcinogen. You can wait, let's say a rat has a 3-year life expectancy, give them a carcinogen at 1 or 2 weeks of life, and then at 1 year give them TSH or iodine deficient diet, and they'll blossom with thyroid cancer. So those studies have been done. But just briefly on the molecular biology, you can see here's the normal thyroid follicular cell. Our group with Henry Bourne and John Lyons and Arguing Science a long time ago found in patients who had hot thyroid nodules, which was truthfully a control. I put it in because I thought it was going to be a true negative, and people wouldn't argue that a hot nodule was going to be cancer. And that was the one that actually had a GAFS mutation. It was a small frequency. Then Dumont's group from Europe showed that TSH receptor mutations were quite common in hot nodules, that, as you know, the risk of cancer in a hot nodule is about 1%. And then you can see that today there's a lot of excitement about BRAF. It appears somewhere between 40 and 60% of patients with garden variety papillary thyroid cancer have BRAF mutation. It's the most common mutation. And BRAF mutation not only goes through the well-differentiated and the occult thyroid cancers, but also especially in tall cell cancers and into anaplastic cancers, whereas the RET mutations seem to be more in the better, less aggressive type tumors. So people are interested in these, and perhaps in the future, when we try to decide whether someone needs a central neck dissection prophylactically or not, you could say that if they're BRAF positive or have a certain molecular profile, we'll do the prophylactic neck dissection. We can use other clinical criteria, which I will get to in the next few minutes. Whereas if they have some other mutation, we could probably not have to do a central neck dissection. We can see the mutations, as I'm sure you're aware of, the RAS and the P10 mutations here were for follicular thyroid cancers, and the PAX8, Dr. Kroll from Brigham in Massachusetts looked at PAX8, PPAR gamma. Those can then convert to follicular thyroid cancer. And then P53 is a late mutation. It's found in virtually all cell lines, those thyroid cancers that go into permanent culture, and also in virtually all anaplastic cancers. And we've done some studies using CGH and other studies showing that the papillary thyroid cancers and the follicular cancers, when they come to become anaplastic thyroid cancers, keep the same genetics. So follicular cancers have many more CGH changes than those with papillary, and they keep the same profiles even when they become anaplastic. So this is one of the best tumors, in my opinion, to study, because you go from a cold papillary cancer where virtually no one will die from this disease. And if you look at the studies from Finland, 36% of patients at autopsy have an occult papillary thyroid cancer, so it's very common, to anaplastic thyroid cancer, where virtually everyone's dead in 6 months of the disease. So what is the reason for the progression, and how can we develop better therapies? Well, we know, and I know you're all aware of this, I won't spend too much time, but there are many ways to classify the tumor as far as predicting of aggressiveness and perhaps predicting whether we should use radioiodine, how much TSH suppression therapy we should use. And these, the Ames classification was from Lake Cady at the Leahy Clinic at that time. And that's age. For some reason, patients over 45 do worse with, and Blake would use 40 for men and 50 for women. Metastases, distant metastases, which about 3% of patients will. The extent is their local invasion and the size, bigger tumors. And the Ian Hay at the Mayo Clinic used age grade. Doesn't look bad under the microscope. The easiest, the EOR to see was the European group, which included medullary and anaplastic, which the others don't. The group classification is the simplest. Stage 1 is confined to the thyroid. Stage 2 is the lymph nodes. Stage 3 is local invasion. And Stage 4 is distant metastases. It's a very simple. I think probably the most accurate, at least in some of the studies we've done, is the MESIS, which is again the Ian Hay Mayo Clinic studies. C stands for completeness of resection. So if the surgeon can't resect the tumor, the patient, now I would say which surgeon and which tumor, because some people can resect more tumor than other people can. But generally with the same surgeon, if the surgeon can't resect the tumor, that patient has a worse prognosis. Now, not all these classifications, like the Ames and Ages, don't even include lymph nodes, whereas the Groot does, and the TNM class include lymph nodes as a factor influence both recurrence and survival. So that's one of the issues I want to address. So the late Jacob Robbins at the NIH said, although the mortality rate for thyroid cancer is low, it is highest among cancers affecting the endocrine glands. And Jack had another, I thought, brilliant statement that said thyroid lobectomy is an acceptable operation for patients with thyroid cancer. Generally, these would be small thyroid cancers confined to one lobe, if you don't plan any other therapy. So if you're not planning to use radioactive iodine, you're not planning to follow your patient, then lobectomy is an acceptable operation. Also for patients who are non-compliant or mentally deficient and can't get thyroid hormone, then you can probably do a lobectomy. I remember a patient from Eritrea where he wasn't going to be able to get presumably thyroid hormone. We just did a lobectomy, even though I didn't think that was the best operation for him, but for his particular situation, it turned out to be the best. So you can spend a whole lecture on whether we do total thyroidectomy or not. I'll just, the next 2 slides, because we're trying to summarize in a short period of time. First, on recurrent thyroid cancer, this is from Clive Grant, surgeon, and Ian Hay and their colleagues, John Van Heerden and others at the Mayo Clinic, in patients at low risk. So these patients had the garden variety, less than 2 centimeter papillary thyroid cancer. There was a significantly higher recurrence rate after unilateral resection compared to bilateral resection, 14 versus 2%, respectively. Amongst patients high risk, the data are 45%, 20%. So you don't really even need sophisticated statistics to show a difference here. And why does the Mayo Clinic talk about bilateral and unilateral procedures, not total thyroidectomy versus less than total thyroidectomy? Because if you look at the data, the Mayo Clinic used to, because they were in the goiter belt in the United States, used to do 14 thyroid operations in one day in the operating room. Well, you don't do 14 total thyroid, in my experience, you don't do 14 total thyroidectomies in the operating room and have an acceptable complication rate. If you look at the studies by Ollie Beers, sort of written in the studies in the 50s, they showed their complication rate of hypopara when they did total thyroidectomy was 50%, not 5%, 50%. So they obviously, you have no referral pretty soon if everybody you're operating on, or half the people you're operating on, have hypopara over and above the problems for the patient and management of hypopara. So initially the Mayo Clinic surgeons talked about bilateral procedures but not total thyroidectomy. They would say near total thyroidectomy. Now they're doing total thyroidectomy for the vast majority of their patients because they do it safely, but they're doing 4 cases a day, not 14 cases a day. Well, this is, I think, a very important study which was presented to the American Surgical by Bill Amoria, who was a fellow for the American College of Surgeons and cord surgeon, one of our previous fellows. And they had the National Cancer American College of Surgeons database. And I think that the study is important. Many people wanted to study a prospective study, lobectomy versus total thyroidectomy for patients with papillary thyroid cancer. But Rob Ludelsman and others showed you needed probably 8,000 patients to show a difference. Well, no one's going to fund such a study because it requires so many patients. But this study, just by its volume, I think is important. So they had about 83% of their patients were treated with total and near total thyroidectomy, about 17% by the lobectomy. For all patients, lobectomy was associated with a 57% higher risk of recurrence and a 21% higher risk of death compared with total thyroidectomy, respectively. So when you did a lesser operation, the patient paid the penalty of doing a lesser operation. And then the real question, because of the TNM classification changing from tumors in the 5th series, where it said 1 centimeter was a T1 lesion, for the 6th series, it said T2 lesions were T1 lesions were up to 2 centimeters in size. They addressed for papillary thyroid cancers between 1 and 2 centimeters, which is probably most of them. They had a 24% higher risk of recurrence when they did a unilateral procedure and a higher rate of death. So it appears that I think most people would now accept that if you can do it safely, total thyroidectomy appears to be the treatment of choice. And we'll come back to that. So hopefully that's just, we can have questions on that later. The issue I wanted to address, and you asked me to address in this lecture, is lymph nodes. And here you can see just pictures of lymph nodes, classical lymph nodes. And the problem with lymph nodes after total thyroidectomy, usually the radiologist or you use the thyroid as the acoustic shadow, and you can see all the lymph nodes around it and adjacent to the jugular vein. So it's hard if you just see the pictures without doing the scan to know exactly where they're situated. And I'll come back near the end of our lecture, but we found for redo, especially central neck operations, we now inject methylene blue into the node under ultrasound guidance in the operating room. It makes a long day, sometimes a very short day, because you know exactly it's the same tumor that they biopsied and showed it was papillary cancer, and you can go focus right towards the node rather than getting worried about the nerve and parathyroids that are close by. Well, this was, I was reading Science Times on Tuesday in the New York Times. They always talked, it was the oracles of Delphi were used to being able to predict the future. And they lived in Delphi. They were supposed to be beautiful women under 30 years of age. And I always thought they got them drunk on wine. But as it turned out in this article, they went down in the caves below Delphi, and there's ethylene chloride, which is an anesthetic agent. And these women probably went through the second stage of the excitement stage of anesthesia, and then came up and made these proclamations on whether you should do this or do that. And they could predict the future. And they tried to downplay ambition. So anyway, always feel for the Delphian lymph node, which is just above your cricoid cartilage in any patient with a thyroid nodule, because sometimes you'll feel a little nodule there. Oliver Coach from the Mass General popularized the Delphian node as an early or a harbinger of malignancy in the thyroid gland. Actually, where we see most is Hashimoto's thyroiditis, but they can be involved there and important. Well, how many nodes do you have? I think it's an interesting study, but nodes can go up to 300 nodes in the neck. That's an enormous number of nodes, because patients, I'm sure, often ask you and ask me, they'll say, well, if you take out 20 or 30 of my nodes, are there any nodes left? And they say, yes, unfortunately, there aren't many nodes left, I'm sure. They're usually microscopic, and we don't take them out if we don't see them. This, I think, is very useful information from Greba and Ian Hay again from the Mayo Clinic. Here you see at presentation coming down this way. This is papillary, almost 2,000 patients. Follicular cancer, which is usually about 10%, and Hürthle cell cancer. Here, so you can see at the initial operation, about 40% of patients will have lymph nodes involved with papillary, only 4 with follicular. So follicular cancer, in my experience, is only the really large follicular cancers that have lymph nodes. You don't really have to do, certainly don't do prophylactic neck dissections in follicular thyroid cancer. In Hürthle cell, maybe you have to be more concerned because even though the initial number is lower, only 14%, certainly different from follicular, which some people classify these the same. I think they're different and shouldn't be. But you can see at 30 years, the accumulated rate here is getting up fairly high. And as you know, Hürthle cell tumors rarely take up radioactive iodine, and radioiodine is not effective, whereas some patients with follicular thyroid cancer, radioiodine can be effective. So probably the molecular profiles of these will even be more useful in the future, but we know that the nodes work differently. And I'll get back to that. So this is what I mentioned in the beginning, Jerry Doherty, David Cooper. David is an endocrinologist in the Johns Hopkins system, and Jerry Doherty is now chief of general surgery and endocrine surgery at the University of Michigan. But in this guidelines from 2006, which is about ready to be redone or republished, they say recommended to consider total or near total thyroidectomy with level 6 node dissection. So the question is, and most of the studies show when you do this operation, you find more nodes. The question is, are we benefiting our patients? They're going to change that recommendation, by the way, but I won't tell you what it is, but you'll be able to read it pretty soon. It'll be in JCNM or thyroid thing. This was an interesting study, and one that I think led to the American Thyroid Association making this suggestion by Lee Delbridge's group, the CWAC, where he did 447 patients with clinically negative nodes by ultrasound and by vision with papillary thyroid cancer treated by either total thyroidectomy alone or with total thyroidectomy with level 6 node dissection. And that's just, here's a big, I should underline it, ipsilateral. So he only did it on the side of the dominant tumor, not the contralateral side. And these were done not randomly or prospectively. He did all the ones with total thyroidectomy alone first, and then total thyroidectomy with prophylactic neck dissection. So he may have become a better surgeon, and certainly the technology with ultrasound and other things may have improved during the time. So it's a flawed study to begin with, but most of our surgical studies are flawed studies, I would guess. Don't quote me on that. But here we see that the tumor size was pretty similar in the two groups, 2.3. The Mason's classifications were quite similar. The blood thyroid volumes were higher after total thyroidectomy, so it means it was a less thorough operation, 9.3, than in those having total thyroidectomy and lymph node dissection, 0.4, and fewer patients, I think this is important, with post-ablative total thyroidectomy alone. So they had radioiodine after in both groups alone, 43% versus 72% had undetectable thyroid volumes. So I think these led to the American Thyroid Association making their decision, but I'm not sure. I think there was a lot of selection in this data to my own prejudice. More recently, just at the American Association of Endocrine Surgeons in Adelaide a couple months ago, the Mayo Clinic group again looked at 421 patients who, quote, met optimized criteria. Again, ultrasound negative and surgeon negative. They found what most people have found was multicentric tumor. Multicentric tumor, what does that mean? If you have multicentric papillary thyroid cancer, you're more likely to have nodal involvement. The same would be true if you do an ultrasound and you see a very irregular primary cancer in the thyroid gland. It's more often associated with lymph node metastasis. But pretty much what we all see about the size of the tumor was a little bit smaller than what I saw before, or mentioned before in the extrathyroidal invasion was about 53% with lymph node metastases. So they found 51% in the central neck and 20% in the lateral neck. Now the central neck is a big area, and so you question if you find a delta in the lymph node, that creates no increased risk to remove that node. And sometimes if you don't know it's papillary cancer, take that node out quickly, send it for frozen section, and they can often tell if it's involved with papillary cancer. The question is when you have nodes all the way along the recurrent laryngeal nerve or fibrofatty tissue and no nodes along the recurrent laryngeal nerve, and especially all the way around the lower parathyroid gland, do you want to take that parathyroid gland, sample it to make sure it is parathyroid gland, and then auto-transplant it? So those are some of the issues. And they found that they were mostly low-risk patients. And what did they find? They found a 11% recurrence rate, 5 in the soft tissues, 8 distant, and 11 of these patients, 11% had recurrence in lymph nodes. And so, which patient is most prone to develop recurrent lymph nodes? It's the patient who has the most lymph nodes initially, even if they had a prophylactic or therapeutic operation. And they did, I guess we should all go there for surgery because they certainly have great results. Now, in contrast to what I said before, with a less than 1% frequency of hypopara. In my review of the patients who have had prophylactic versus therapeutic neck dissections, prophylactic central neck dissection versus selective, we think it increases the risk. If you look at Jean-François Henry, and I'll show you that slide, increases the risk of hypopara from about 1 to 4%. That would be our estimate. Their study didn't show that. They showed they could do it very safely. I mentioned a study already by the late Joe Addy and Shiro Noguchi from the Noguchi Clinic in Beppu, Japan. Separate studies, and there were numerous other studies. But when prophylactic dissections were previously done, metastases were found in approximately, it would really be 80% of patients with papillary thyroid cancer. Anyone with and the Noguchi study showed anyone with a nodal metastasis larger than 3 millimeters also had cancer in the smaller lymphatics. So that's really a good reason not to do berry picking. In other words, just take out one node because you're going to be back there again taking out more nodes. So most people think you should do a functional, especially lateral neck now, clean out all the nodes and fibrofatty tissue but relieving the nerves, muscles, and other vital structures. And this just shows you the distribution of nodes from the Morales studies from Europe. And this should be actually, this shows you, let's see it. Anyway, you can see it should be, it says level 1, should probably be level 2. Those are really the hyoid bones, lateral to the carotid and jugular. The mid-jugular is level 3, where most of the nodes are involved. In patients with, as one of the questions in the previous lecture, if you have a lesion high in your thyroid gland, it's more likely to be level 2 and level 3. Whereas if it's mid or lower, it'll be level 3 and level 4. The supraclavicular area or subclavic area is level 7, and the posterior ankle is level 5. And you can see this is a little bit lower. The contralateral side still has nodes, but it's a smaller number. Well, I think this was a summary slide of and I could put probably other articles up here, of what are the clinical consequences of lymph node metastases in patients with papillary thyroid cancer. And back in 1976, Blake Cady and group from the Leahy Clinic said that actually having lymph nodes in papillary thyroid cancer was beneficial. We, and then Jim Harwood and Dr. Dunphy and I looked up our own series in San Francisco, and because I didn't think there were any tumors where having lymph nodes were positive. What Dr. Cady thought is that some of the papillary thyroid cancers, that patients who had lymph nodes differed from those who didn't have lymph nodes, just like, as I mentioned already, the follicular cancers often don't have lymph nodes. So he thought they were completely different cancers. However, we're not really talking about, if you look at the data, it's really not patients who have lymph nodes or don't have lymph nodes, because, as I mentioned, when you did prophylactic dissection, even in the elderly, 80% had lymph nodes. So you're talking about clinically positive lymph nodes versus microscopic lymph nodes. So Blake, I think, was a little bit confused. The differences are, if you're young, you do better when you have lymph nodes than if you're old and don't have lymph nodes. So being young is a more positive factor than having lymph nodes is a negative factor. And then numerous other studies, Ian Hayes' studies didn't show any really great difference. I'm really surprised about that. He did show a difference in recurrence, but not survival. But we know, what do you know in patients who have recurrent thyroid cancer? A third of those patients are going to eventually die of thyroid cancer unless they die of something else first. So recurrent cancer is not good, although if you want to recur, the safest place to recur is in your lymph nodes. And Dr. Beyer from the EORTC showed the lymph nodes were detrimental, especially if they were extranodal invasion. And the studies from Japan, the Noguchi Clinic again, showed that if there was, they looked at the nodes and then microscopically, if there was extranodal invasion or matted nodes, those patients did worse and had a worse prognosis. Many Mazaferi studies showed the same lymph nodes were detrimental, both from recurrence and survival, although minimally so, but true. Dr. Schumann from Germany, again, showed lymph nodes were detrimental. And this study by Lundgren, a recent study from Sweden, over 500 matched patients, showed that having lymph nodes were detrimental to both recurrence and survival. The next study by Zafarin, or Dufin, which was presented at the American Association of Endocrine Surgeons a year or so ago, using the SEER database, and you can see the beauty of the SEER database is a large number of patients, found lymph nodes actually in papillary thyroid cancer only made a difference in patients over 45 years of age, not in younger patients, or follicular cancers, that whether you were younger or older than 45, lymph nodes had an adverse effect. So overall, I think you put all this information together, you'd say lymph nodes are bad, but they're not horrible. And this was the Swedish study. They looked at 595 cases versus the controls, the Oncozenius and Lundgren. And regional lymph node could increase the risk of recurrence and death due to thyroid cancer. So, but it's a moderate effect, not a dramatic effect. So how are we going to treat these patients? And what do we know about lymph nodes? Nobu Wada, one of our previous fellows at Guangzhou, in analysis surgery, looked at lymph node metastases are present, like most other studies, in 40 to 60% of patients, even with micro, this is papillary microcancer, which they defined at under 1 centimeter. That palpable and sonographic metastatic nodes, but not those identified at histological examination, are associated with worse relapse-free and overall survival. So that if you feel nodes, obviously you're not going to leave the nodes. If you don't feel the nodes, and the way they did the study is when they found some of their patients had a cold papillary cancers, they didn't know their routine thing was to do a prophylactic neck dissection. But if they didn't know they had cancer, they didn't do the neck dissection, they thought it was benign disease. They found coexistent incidental thyroid cancers. They didn't reoperate on those patients, and they did just as well with microscopic nodes as those they did do the prophylactic dissection in the first place. So what, if we're trying to decide now, how should we treat a particular patient? What factors can we use? Should we really do prophylactics, at least ipsilateral neck dissection versus selective? If you see nodes, take them out. Certainly multifocal tumor is more often associated with lymph node metastasis. Virtually numerous studies document that, including our own. The larger the primary tumor, so if you have a very big tumor, it's much more likely that lymph nodes are going to be involved, and there'll be more nodes in the central neck. So maybe those patients should have a central neck dissection. Extrathyroidal spread and distant metastases are more often associated with nodal metastases, as is the poorly differentiated tumors, such as the tall cell tumors, the columnar tumors, and the papillary sclerosing tumors certainly have many more lymph nodes. Children seem to have larger nodes than adults, about 60%, and more likely to have nodes involved. And when the lateral nodes are involved, most of the patients have central nodes involved, although Natchez, again, in the group from Germany, reported that the skip metastases occur in about 20% of patients where there are none in the central neck, but they're in the lateral neck. Most patients who recur, in my experience, in patients who've had selective central neck dissections, recur not in the central neck, but in the lateral neck, which you can manage fairly simply, and unless the tumor directly invades the internal jugular vein, it doesn't seem to increase the risk of distant metastasis. The extent of operation, obviously the more you do, the more likely you're going to find nodes, and that also depends on the thoroughness of your pathologist. If they look for lesions up to 1 millimeter or so in the lymph nodes, they're more likely to find more disease. Well, if prophylactic neck dissection were not associated with the potential for increased complications, I think everyone would do it. And we do it for medullary thyroid cancer, and we do it relatively safely, but the question is, do the benefits outweigh the risk? And I don't know the answer to that. But at Jean-François Henry from Marseille, I think this is fairly, and I mentioned this already, if you look at here, he did 100 patients, 50 for toxic goiter and 50 for papillary cancer. So not the same operations. Slightly different. Papillaries can be more invasive, more difficult. But if you look at this, when he did total thyroidectomy and node dissection versus just total thyroidectomy alone, the risk of permanent hypopara, which I think is a bad disease, increased, I would say, probably from 1 to 4%. So I think there is, and there are other studies showing the exact same studies, although not all. I just read an article in, I think it was in surgery, just the recent surgery from Texas group, Little Laymore's group, where they showed no higher risk of complications, but I'm a little bit suspect. Well, I mentioned before, perhaps the molecular profile will be able to direct us to do one operation or versus a more extensive operation, less extensive. This is a nice study, and there are numerous other studies. And if you did a meta-analysis of the literature, most studies would suggest that if you have a BRAF mutation, you're more likely to have lymph node metastases than if you do not. In our own particular medical center now, the pathologists are doing BRAF mutations on all our thyroid cancers over 6 millimeters. So we'll have that information. Whereas if they're BRAF negative, only 17% of the patients had lymph node metastases. So that's another way you might be able to select your tumors for your patients for an appropriate operation. Well, there's some other new information looking at chemokine receptor expression. As you can see illustrated here, chemokine receptor expression 3, 7, and 4 were evaluated in papillary thyroid cancers and non-malignant thyroid tissues by immunohistochemistry and flow cytometry. All were increasingly expressed in papillary thyroid cancer, and increased CR4 expression was present in papillary thyroid cancers from patients with lymph node metastases. So there may be other molecular groups that we want to look at. The same data is presented here by Tom Fahey's group at Cornell. The chemokine receptors CXCR4 and CXCR7 are associated with tumor size and pathological indicators of tumor aggressiveness in papillary thyroid carcinoma. So again, molecular profiles may help us in the future, but we need more information. One other study before I close is that the monocyte chemotype protein, MCP1, is a chemokine ligand that promotes the migration of leukocytes. Expression of MCP1 by immunohistochemistry, so it's a fairly easy thing to do, is present in the cytoplasm and stroma of papillary thyroid cancers in greater than 80% of these tumors. And the MPC1 positively correlated with tumor size and lymph node involvement. It was an independent predictor for recurrent papillary thyroid cancer. So I think all this information needs to be probably repeated by other groups, but looks promising. And another is the RET-PDC3 oncoprotein increases the risk of MCP1. Oncogene-induced cytokine signaling pathways are related to inflammation and cancer, which might get back to the desmoplastic reactions we were talking about in the medullary thyroid cancers or in the poorly differentiated papillary cancer. Well, how do we do the operation? Basically, for resection of all fibrofatty tissue, the Delphi nodes I've mentioned, from a carotid sheath and to the trachea, and from the innominate vein to about the level of the upper thyroid cartilage. Some of the people say for a true central neck dissection you have to go to the hyoid bone, but I don't think anybody does it, truthfully, in the central neck, in the lateral neck, certainly. It's easier to preserve the upper parathyroid, as I'm sure you all know. The upper parathyroid is more dorsal. It's usually right at the cricoid cartilage. The upper parathyroid is more consistent in position, which you know if you do thyroid or parathyroid, about 92% of the upper parathyroids are exactly where they should be, versus about 80% of the lower parathyroids, which can migrate with the thymus or in other areas. Do you take out the upper thymus, the thyrothymic ligament? I don't know the answer to that. A recent study from Bruno Carnay, the French group in Lille, suggests that they found in a small number of patients thyroid cancer within the thymus. Truthfully, most of us find thyroid cancer all the way around the thymus, but not in it. But if you do prophylactic upper thymectomy during thyroid surgery, always cut into the thymus, because they're often about 15% will have a parathyroid in the thymus, then you would want to auto-transplant that gland. So don't make anybody hypoparathyroid. So generally when I do a neck dissection, I begin at level 3, that's sort of just lateral to the thyroid gland. We mobilize the sternocleidomastoid muscle posteriorly. I used to go both anteriorly. I used to go both anterior and posterior and divide the muscle and then sew it back together. Some of those patients got fibrosis of their muscle, a lot of some disability. So just mobilize anterior. Level 3 is, I think, the safest because you're not worried about losing control of big vessels beneath the clavicles. and then mobilize that tissue off the scalenus anticus muscle, anterior scalene muscle, and the phrenic nerve. You'll see the brachus or feel the brachial plexus just lateral and posterior to that. And then you'll pull the tissue out from level 5 underneath the sternocleidomastoid muscle. And then you can pull the level 4 level up and level 7 from up the sphere mediastinum, all this fibrofatty tissue to get it's actually a beautiful dissection. Then you march, at least march in a cephalad direction, now looking for the cervical sensory nerves. Probably saving the cervical sensory nerves, I think is very useful because patients have a numb shoulder if you don't do that. It probably breaks some cancer principles because you're dissecting and breaking into the fibrofatty tissue a little bit, but I think it's very good for the patients. And then taking the level 3 nodes that we've mentioned already have already been mobilized. If the level 3 nodes are positive or big, then we take level 2 nodes. Generally for level 2 nodes we make a separate incision. I don't like the vertical incision. I don't think it is cosmetically as good as making a separate incision parallel with the lower incision. You almost have to do that to get the high level 2 nodes. Where we've missed nodes, and Dr. Perron, one of our previous fellows, reported where we've missed nodes is those level 2 nodes. And our ultrasonographers don't like to even look at level 2 nodes because so many people have level 2 nodes that are not involved, are abnormal, well, are big in the first place, but most of them have a fatty hyaline, so can be, I guess, ignored unless they change in size over time. So then we clean out all those nodes. The best, I don't use drains unless the patient has a tremendous amount of fibrofatty tissue, either in thyroidectomy or in neck dissections, and we've been happy with that. And it makes it simple, and the vast majority of patients go home on the first post-operative day, which I'm sure that some of the fellows who have seen that would agree with. So, to summarize, lymph node metastases are common in papillary thyroid cancer, up to 60–80%, but not inflicted thyroid cancer, suggesting different molecular mechanisms. I've showed you some of those, the TPR gamma axate versus the BRAF. Therapeutic central and lateral neck dissections are indicated for palpable or abnormal nodes, and nodes observed on ultrasonography or at operation. So if you see nodes, you certainly need to take them out. I think we need more evidence to know whether one should do a prophylactic neck dissection, central neck dissection. I don't think anyone's recommending a prophylactic lateral neck dissection yet, although when I was a resident, that's what we did until the studies that I mentioned by Cutter and Foote suggested that wasn't necessary. You can wait and see if those patients develop nodes. So our technology now is so good with thyroglobulin ultrasound that we're dissecting. If you didn't have those studies, the patients would be cured. Once you have those studies, you can diagnose very early disease, which should be good for the patient, but we're not sure because many of these thyroid cancers, probably only 1 in 10 ever grow. But the question is predicting which 1 in 10. So I think we have more to learn. I would be cautious. I would follow, maybe if you plan to do prophylactic, do it on the side of the tumor and leave the other side because you have 2 parathyroids then that at least aren't the potential of such vascular ischemia. And I appreciate your attention and look forward to some questions